It's great to have so many of you joining us today. And this is actually our last forum with the Cabinet for Health and Family Services for the year. This year has absolutely flown by. I hope everyone is doing well. I'm Emily Beauregard. I'm the Director of Kentucky Voices for Health and a member of the ThriveKY campaign. For those of you who may be joining us for the first time, or if you're just not familiar with the work that we do as part of ThriveKY, our mission is to meet the basic needs of every Kentuckian through systemic change because we recognize that there have been many historic and systemic barriers for Kentuckians to meet their basic needs. And you can see the principles that guide our work on the next slide if we move forward. And don't feel like you have to read all of this now. We send out these slides along with the recording and any materials that we share in the chat and a follow-up email. So just take a look when you've got a moment, and we can go to the next slide. If you're interested in learning more about any of the organizations that are part of Thrive Kentucky, you can access links to our website here. So again, just when you've got a moment, if you want to know more about the work that any of our individual organizations are doing, that's a good place to start. We can go to the next slide. We always like to thank our sponsors for supporting this work. It helps us to provide these webinars as well as our in-person events for free at no cost, along with CEUs for community health workers and for social workers. And we just really appreciate having the ability to provide this information, these state and federal updates, the forums with the Cabinet for Health and Family Services to Kentuckians who are on the ground every day in their communities, helping people to access these really vital programs and services and navigate what is too often a very complicated system. So appreciate that support. We accept new sponsorships at any time throughout the year, and now we are really looking forward to 2026 and sponsoring and supporting that program for the new year. So if anyone is interested and wants to learn more, there's a link to a sponsorship flyer on this slide. You can also reach out to Kelly Tolby, and I see that she's already put her information in the chat. Why don't we go to the next slide? I mentioned our webinars, our forums, our roadshow events. You can see what the schedule looked like for 2025 here. Of course, we are down to just our last two events today, and then December 15th, we're going to be doing a virtual roadshow. So if you weren't able to make it to one of our in-person sessions this year, and you want to catch up on what you might have missed, or if you just want a refresher, please join us on December 15th for our very last event of the year. And before that, I'll just put a really quick pitch in for KVH's annual meeting on December 9th in Lexington. And then of course, we'll have a new schedule for 2026 out soon. Why don't we go to the next slide? So here's the agenda that we'll be covering this afternoon. Between our last forum in August and today, we went through the longest federal shutdown in history. And I know that many of your organizations and the communities that you serve have been really deeply impacted by delays in funding and all the other uncertainties and disruptions that come along with a shutdown. And while we are really relieved to have the federal government reopened with programs like SNAP, operating, issuing benefits again, we know the window for extending enhanced premium tax credits that make the plans on our Connect marketplace affordable for about 100,000 Kentuckians. That window is getting smaller. And that's something that we're going to be talking about more today. And to get us started with all of these updates, we are delighted to have joining us today Deputy Secretary Tricia Okeson, Medicaid Senior Deputy Commissioner Veronica Judy Cecil, Medicaid Deputy Commissioner Dr. Leslie Hoffman, Division of Health Plan Oversight Assistant Director David Very, Department for Community-Based Services Commissioner Lisa Dennis, Director of the Division of Family Support Roger McCann, and Tanya Dickinson, Special Projects for the Department for Behavioral Health. We may also have some other CHFS leadership on the call. We often do, and they may choose to weigh in while we're talking or in the chat, but we really appreciate you all being here, providing so much of your time to provide these updates for us. And we want the goal, our goal of these forums is to create more open dialogue between cabinet leadership, consumers, and advocates. And we always want this to be an opportunity for our boots on the ground to get updates on safety net programs, to share feedback with the cabinet on what's working, what may not be working so well, and to ask questions. So during each section, be sure to put any questions or comments that you have in the chat. We're going to try to cover those as we go. You may notice that you're seeing presenters on the screen today and not each other. And we have some new security measures in place because we don't want to be Zoom bombed again. So just know that we very much appreciate your participation and your engagement. We want to see that activity happening in the chat. And we hope that the security measures that we put in place are going to work out for us. So just a little bit more housekeeping before we begin. I think lines are muted, but if they're not, be sure to mute your line while we're talking. We are going to be sending out a recording to this webinar or of this webinar and any materials, including the slides, along with an evaluation in the follow-up email. So watch for that tomorrow. We appreciate that evaluation because it helps us identify, what topics we want to cover on our next call. If you're a certified community health worker or a social worker and you want to receive CEUs for attending today's webinar, please be sure to complete that evaluation. That's a requirement for CEUs. But like I said, we want everyone's feedback. And with that, we can go to the next slide. I'm going to turn it over to Kelly to start us off with some federal updates.
Thank you, Emily. My name is Kelly Talby, she, her. I'm the Director of Policy and Strategic Partnerships at Kentucky Voices for Health. Federal updates. We are thankfully on the other side of what is now the longest federal shutdown in U.S. history. I think historically, previous to the 43-day long shutdown that we just ended and saw pass us, was at the end of 2018 and 2019. The federal government is now funded through the end of January. And I want to say that so that it gives us a little point of focus on some of the updates we received today, knowing that another resolution is going to be necessary pretty soon after the holidays in order to keep the federal government up and running. And I do also want to lean in on what we're going to talk about: SNAP, just overview on the Cabinet for Health and Family Services with staffing, anything related to LIHEAP. There was a lot of headlines, right? And I want to pass the virtual mic to Deputy Secretary Okeson, who's going to share some of the latest as far as what people need to know, even if it's just reminders of what you've maybe seen over the last 2 or 3 days. But also I want to start with a little bit of gratitude in the month of gratitude. When headlines are crazy, when information is fast-paced, when you're combating confusion, misinformation, and then also just the reality of way too many sticks in the pot at once. It takes a lot of measured intention and judiciousness to make some of the decisions that you all do so that Kentuckians don't feel the direct impact of harm when that is our unfortunate reality. So I want to hand the virtual mic to you, Deputy Secretary, with a little bit of high five on the way.
Awesome. Thank you so much for that, Kelly. I really appreciate it, and I hope that the CHFS folks on the call appreciate it as well. I know they do, and I'll turn the gratitude back to you guys and the other folks on this call because it takes all of us really communicating with people and raising questions and having an opportunity like this to talk about the things that we need to talk about, the things that we're hearing, because we are hearing a lot. And I'm confident that, and I know this is happening, but we try to minimize the impact. We try to minimize that whiplash that we can see all during shutdown, the different directives, the tweets that go out that we think are going to impact our programs. We try to minimize all of that. And so I feel like we have done the best that we could in in controlling the message and making sure we're getting the right message out and not responding to rumors and things like that. So that means a lot, Kelly. That was one of our goals. When we first put this on the agenda, this was going to be a completely different conversation than it is today. So thank goodness we've got our programs up and running again. We've got the federal funds are flowing again, and we can continue serving folks. So I'll talk a little bit about what were the impacts. I mean, saw newspaper articles, online articles, tweets, all those things. The impacts for most of our programs, what we were able to do in Kentucky because of a variety of things, is continue serving people. So many of our programs, like TANF, we were able to continue providing the November benefits, and we were ready to provide the December benefits again, should we have needed to. Our WIC program was maintained and moved as normal through the shutdown. Connect, the health benefit exchange, and David will talk more about that. They were open for business, as well as Medicaid, completely open for business as usual. But I think that people heard the news articles, they heard the rumors, and assumed that those programs were shut down because of the federal shutdown. If you're hearing from your folks that think that that is still the case, please let them know that these programs are up and running and they're ready to serve. The SNAP was the one that we heard most about in the news. And that one was the one that gave us some whiplash too. But we took every opportunity that we could, with the support of the governor's office, to continue the benefits to the best that we could. We also did not go further than we thought we would be able to work out. So we were able to provide 65%, and that doesn't mean for an individual it's 65% of what they should have received for the whole month. It's the most cumbersome calculation I've ever seen, but thankfully a lot of people know how to do that calculation. But we were able to go, we thought up to 50%, then the feds came back and FNS came back and said, no, you can go to 65%. So we immediately did that. We had teams in DCBS and our IT teams, we call it OATS, Office of Administration Technology Services, stay up all night working with our vendor Deloitte to get the files sent to the vendor that actually puts the money on the cards. What a lot of people don't know is we don't have the money in Kentucky for SNAP. The federal government has that money, but what we do is we determine eligibility. We send that file to a vendor who actually loads the money on the card. So we did not have the money in Kentucky to actually put on the cards. Our team has worked overnight again as soon as the shutdown was over to restore all of the benefits, the full amount of the benefits for November onto those cards. So if you are hearing folks say, hey, I don't have what I thought I would have, I'm going to ask Roger, I hope Roger's listening, if you don't mind putting a way for folks to contact DCBS and see, so that they can ask questions if they don't have the funds on their card that they believe they had. So hopefully he can hear me.
I can hear you.
Okay, awesome.
Well,
Go ahead. Go ahead, Roger.
I was going to say that obviously folks can reach out to their local DCBS office, or they can call our 800 number. I'll put that information in the chat for you, but that would be the normal process that we would ask for folks to go. Looks like maybe somebody already put something there, so thank you.
I got your backs, Roger.
Thank you, Kelly. And then I'll just address one other quick question that we've heard a lot. We've heard a lot about what about the staffing at CHFS? What about, our state staff? Because of the shutdown, we really did not see impacts on our staffing. Now, at some point, if it went on long enough, we may have had to make some tough decisions, but even with the longest shutdown in federal history, we were able to maintain our staffing. So we are ready to go, open for business, and let's get people served. Were there any other questions, Kelly?
I think the specific to SNAP, and this is still kind of new. I think we're all still waiting to see whatever comes of it. But the latest announcement from the federal level is that all SNAP recipients may have to reapply. That is not, please correct me if I'm wrong, Roger or Tricia, but I think that's maybe the intent right now. But until that is the rule, it is just business as usual. Folks should continue receiving their SNAP benefits. If anything does change, I have a hunch that you all will be sending out a tremendous amount of information and notices related to that. But that did also come out as like a tail feather headline shortly after the federal government opened late last week.
Right. And yeah, you're exactly right. I'm kind of wondering if it's a terminology because we are going to have to recertify people. And I think Roger's going to talk about that in just a little bit. I'm hoping that that statement was really a terminology, using the word reapply versus recertification. Doesn't make a lot of sense to me for everyone to have to reapply. But we have not heard anything official from FNS on that, and we have seen that sometimes those tweets that come out are not exactly what turns up in the actual guidance from FNS. So thanks for that question.
Yeah, I'm gonna pass the virtual mic for kind of like a peripheral federal update to Emily, but I want to leave everyone in this room and for those who watch later, use this as an opportunity in the coming weeks to take your experience, the experience of your clients and patients, reach out to your lawmakers, remind them how critical these programs and services are, how they have been, and how, as we tiptoe towards January pretty quickly, we cannot risk another federal shutdown. There are real Kentuckians at the end of all of these policies, real families, real children, people who can't be used as pawns. And so please reach out to your lawmakers, explain your programs, explain what the programs mean to your families. Use this as an opportunity. And then I'll pass it back to Emily.
I have one more thing, Emily,
Oh, yeah.
before you take over. I neglected to mention LIHEAP. As far as LIHEAP, the shutdown really did not impact, and it had to do with the timing that we had money. We had some money that we were still able to spend, so we were in good shape on there. And then my good friend Roger has given me a little cheat sheet over here, and I would be negligent if I did not mention that Kentucky households can enroll at your local community action agency from now until December 12th. So if you've got folks that need some LIHEAP assistance, please help them reach out and apply. And I guess there's 23 of the community action agencies that are helping sign folks up for LIHEAP.
Yeah, well, thank you for that update. I think that's going to be a big relief for a lot of households in Kentucky as the weather gets cold and, of course, as the holidays come near. So we will be sure to share the LIHEAP update as well in our follow-up email. And I know that I think, have some links to the community action agencies and how people can apply, because we often are promoting that ourselves in our newsletter and on social media. So very glad that this shutdown is behind us. But like Kelly said, there will be, a need to extend the budget yet again or pass a full budget in just under 2 months. And so we want to make sure that we're not put back in this position again right after the holidays. Deputy Secretary, I wanted to hand it back to you actually for some updates on the Rural Health Transformation Fund. People may remember that as part of the One Big Beautiful Bill, while $1 trillion has been cut from the Medicaid budget nationally, which trickles down to billions of dollars in cuts here in Kentucky, and really disproportionately impacts Kentucky because we had gained so much through Medicaid expansion, through the hospital rate improvement program, that was paying hospitals the average commercial rate for inpatient and outpatient care, still is actually. Cut hasn't gone into place yet. But knowing that there will be less funding in Kentucky, this Rural Health Transformation Fund, originally envisioned by members of Congress, I believe, is more of a hospital fund to help as they were losing revenue. But as CMS has put out guidance and the application, of course, transitioned more into something focused on innovation and providing services in new and different ways in rural areas with more of a focus on prevention and technology and things that could be sustainable after the fund is, exhausted in 5 years. And so I think that it would be great for us to hear an update on the application that was submitted and the 5 areas of focus, those initiatives that are part of that application.
Sure. Yeah, I'd be happy to. And unfortunately, Dr. John Langfield, who's the commissioner in the Department for Public Health, is leading this project, and he is in DC. I think everybody's in DC this week. So I will do my best to cover this. It's a very complicated grant application, but you hit the nail on the head. This is pennies compared to what the hospitals are losing, and most of this is not going to the hospitals. We can't pay for, provider care, billing, all of those things. There's so many things we can't pay for. It's really, truly is an innovation focused opportunity. So what we can do though is try to, use this opportunity the best we can to try to minimize impacts to individuals. I don't know that we're going to impact or minimize impacts to hospitals, but we have submitted the application. Just a little background on the application. So the total funding is $50 billion. There's the base portion of that, and then there's like a one that's more scored on your application and your metrics and how rural you are, because this is a rural health transformation grant. So it's 50-50. So Kentucky was asked to submit an application with a budget of $200 million per year for 5 years. Now that would be both the base funding plus the enhanced funding. We feel like we will get the base funding for sure, and honestly, we feel pretty good about the enhanced funding. So, but we worked on the application, so we think it's pretty good. So that has been submitted November the 3rd. That was submitted to CMS, and so now we're in the waiting period. And CMS says that they will have the scoring and the awards out in December and money available early 2026. It seems pretty aggressive timeline, but I hope that they are able to do that. It sounds like they're not going to have much of a holiday season there in DC. So the way we went about it, when we first learned about the award, there are so few details. It was just very vague, but we knew we had to engage stakeholders. So we just kind of put out a call and said, hey, stakeholders, please send us your ideas. There were some basic parameters, but we didn't even have the full guidance on the application. So we got about 50 responses from different groups. Some of those groups had combined their ideas and put them together and submitted. Some were individuals. So we really used that to build onto these elements, these 5 areas that Emily talked about that we were going to fund. So let me pull my little cheat sheet here. So the 5 areas are oral health, trauma and EMS, chronic disease management and prevention, behavioral health, and maternal health. And in the application, there were areas that we could choose from. So these are some of those areas we could choose from. There were, I think, 10 or 15 or so that we could choose from. So those are kind of the topic areas, but then threaded through all of this is the innovation piece. So there's a lot of stuff in our application about workforce development, about a collaborative care model, about telehealth, about creating hubs for care so that we can get the care to the individuals who are in the remote areas. So a little bit more about each of those initiatives. We decided to do a a rural community hub for chronic care conditions. And so the idea of that is having a focused hub that we could work on, for example, diabetes. These words are hard to put together. And really looking at that prevention, those prevention activities, and how can we prevent people from getting sick and being in the hospitals in ways that they don't need to be. So that diabetes was kind of the focus initially, but this model will be able to be expanded to other chronic diseases. Excuse me. There was also in our application a big focus on maternal and infant health. So we looked at ways to increase the preventive visits, the preventive interactions with pregnant women, so we can get those early prenatal visits in, and making sure that the mom is delivering a healthy baby, rather than relying on the hospitals once we have a bad outcome. The third one is an empath model, and I don't know if you guys are familiar with empath. It's a model of behavioral health, mental health support. And Tanya, you can probably explain this a lot better than I can. But it has to do with having a place for folks. They don't need to go to the emergency room. They don't, having an alternate place for them to seek care, rather than, interactions with law enforcement, going to the emergency room, things like that. And just having a place where they can come in, they can get immediately assessed and start medications if that's appropriate. And this model is active at UK at Eastern State Hospital, and is really making a big difference in that community on getting people, excuse me, treated very quickly, so that it's again, I think, a prevention model. The fourth one is about dental access, and we're looking at preventive dental care, getting in the schools, getting in the rural communities, looking at mobile services, and even looking at telehealth for dental services. So you could have a provider, even a hygienist at some point, be able to use the telemedicine equipment, consult with a dentist who's an hour away, and get some guidance for folks. There's an interesting piece of this that I think is interesting. It's teaching the ER physicians how to administer a pain shot, an injection, so that when someone comes to the ER and they have dental pain, you can get them out of pain. I mean, you can't fix their broken tooth in the ER, but you could get them out of pain so that they could get treatment at a later time. And finally, the last one is about EMS and trauma response. So we are in Kentucky, we have a trauma system. I don't know if you guys are familiar with that, but there's a trauma certification, rural trauma hospitals, and there's different levels and things like that. But trauma is one of the really lacking areas for our state. And part of that is because of the rural nature and the disconnectedness of our systems. It's really hard to rapidly treat someone that's had a trauma, a car crash, or a head injury, or whatever it may be. So this system that we will build is about pre-hospital care, and working with EMS and trying to get the resources available and the information available. So when someone arrives at that hospital, they can immediately start getting treated. The hospital will know who's coming. They will know the appropriate place to take the folks, and be able to hopefully improve the outcomes for folks that have trauma. So I think I've taken up way more than my 4 minutes, Emily, and I'm so sorry.
Yeah, I think some of those examples were really, really helpful. So thank you. You have a lot of different components to this plan, and it's
Yes.
impressive that you were able to put it together in such a short time frame. And I should note, with the input of about 50, maybe more than 50 stakeholder groups, which not every state did because of that short time frame. We had advocates in other states telling us that there was no opportunity for that kind of input. So we really appreciate the effort that you put into it. And I think those 5 key areas are exactly where we need to be working. Dr. Stack summed it up really well, I thought, at the Moab meeting last week, when he said something to the effect of, if we were doing all of this with the current system that we have today, without cuts on the horizon, this could be truly transformational.
Right.
It is not going to make up for these cuts. It is not going to be, that stopgap. And so I think we're all a little bit more kind of sober about exactly what we can accomplish here. And yet I still think that it's worth the effort. And I'm really looking forward to seeing how much Kentucky is awarded, and then how stakeholders can be involved. Once I'm assuming, and one question, and then I'll pass it on to Dustin. Once the award is, public, and Kentucky knows how much funding will be coming from the federal government for this, what will the next step be for stakeholder engagement?
Well, I anticipate, and I have not been part of the conversation. I know they are working on plans right now, even before the funding comes, with the assumption that there will be some. There will be a lot of outreach to stakeholders, and these 5 areas have different stakeholders, but then some overlapping stakeholders. So I would anticipate some of you guys will be tired of hearing from us. Wanting your input and your thoughts. So we can't do this without our stakeholders. We can't do this in a vacuum. So your ideas, your input, your guidance is going to be crucial. So I don't know exactly what that looks like yet, Emily, but you will be engaged.
Right. And we'll include this on our next agenda for the first forum that we have with the cabinet in 2026.
Perfect. Hopefully we'll have a lot of good news to share.
All right. Thanks again. And I'm going to pass it over to Dustin.
Sounds great. Hey, everybody. Dustin Pugel. I'm the policy director at the Kentucky Center for Economic Policy. So there's been a lot of turbulence within the federal government lately with a lot of these programs that we care about. And we wanted to try and focus a little bit on what's coming, as opposed to what we're sort of getting our feet under us from with the shutdown. So we know that HR1, which was passed this summer, is a really sweeping set of changes to these programs. It's probably the largest single change to our safety net since the '96 Welfare Reform Act. It makes very large cuts, but those cuts take the form of particular policies. Those policies don't all happen at once, though. So if we go into the next slide, I think it's important, if we still have those slides. We may not. We may have gotten rid of those. That's okay. There we go. So some of these have already started. For example, changing the way counties are allowed to waive work reporting for particular participants in SNAP. Some of these changes are down the road. So next year, there's going to be changes to the ways we fund the administration of SNAP. We also know that there are some already, we're going to talk much more about this later, but open enrollment's being affected by a lack of action during HR1. If we go to the next slide, there's also many changes that are happening in out years related to co-pays and the way we fund our state-directed payment programs and so forth. So we wanted to give our friends at CHFS a chance to share a little bit about what those changes are coming down the pike and what they're doing to prepare for them. So Today, we're going to hear from Roger McCann about SNAP, David Very about some changes to the marketplace, or what we call Connect here. And then we'll hear from Judy Cecil about the changes coming to Medicaid. So if we want to start with Roger, and we're running a little bit behind, so we're going to spend about 20 minutes running through each of the total going through these. Roger, if you want to give us a little bit of information about what we can expect to changes to SNAP over the next several years, and a little bit of how the cabinet is preparing for that.
Sure, Dustin. Thanks a lot, and thanks for having me today. So just to touch on something that was mentioned earlier, yes, there was a report in the news, and we had I think the Secretary of USDA said SNAP folks would have to re-enroll. We're assuming that is just a discussion point at this point. Obviously, SNAP folks recertify every 6 months, so that may be exactly what they're referring to. I'm certainly hopeful that that's what they're referring to. And I think that serves that. That's also encoded in the CFR. So I think that would require some sort of change if they were going to restructure that. So at this point, we're just taking that as a talking point it's in the media out there.
Good.
No, you're absolutely right. There's a lot of changes that HR1 put out there, and I'll go through them fairly quickly, and I'll slow down on some of the more important ones. So back in September, we received notice that we needed that Kentucky had a waiver that allowed folks to use their internet expense as part of their shelter expense. And those expenses are important when you're calculating eligibility and the SNAP allocation for a household. We already went ahead and put that in place, and we did what we call a data fix. We remove it electronically from households that were using it. There were quite a few households that used it, and quite a few that were actually receiving a little bit more in SNAP allocation because of that. But that went into effect in their October benefits. The other thing that happened is that HR1 folks can have that automatic standard utility allowance if they receive energy assistance. And in Kentucky, that's LIHEAP. So a household that receives LIHEAP would automatically, and we do it electronically, we send a file over, and it automatically gives folks that SUA. We can go in there and turn that on for those folks. HR1 changed that, so that only applies now if there is an elderly individual or a person with a disability in that household. So it dramatically changes the number of folks who can use that automatic SUA. That doesn't go into effect. It's gone into effect, but it will show up in people's recalculation on recertification. So when people enroll new or recertify, that's when that will go into effect. There's a lot of things around what they're terming the alien eligibility or the citizenship requirements. The HR1 changes that. But what I want to talk mostly about, because it's impacting folks right now, is the ABOD changes. So ABOD, the able-bodied adult with dependent. So you always had a requirement to report work if you were an ABOD. And in a lot of counties in Kentucky, that was waived. And I'll get to that in a second. But what HR1 did was it changed the definition of an adult. So an adult was 18 to 54. Now it's 18 to 64. So we just added 10 years in the definition. So HR1 broadened the scope of what an adult is. So it increased the number of people. The other thing it does is on the dependent side, it was anyone less than 18. A dependent was classified as someone less than 18. Now it reduces that to 14. So you're again taking a lot of folks out that were excluded before, and now you're putting them in that pool. There's a lot more folks that will classify as ABOD. There were some exemptions for folks that were veterans, unhoused, homeless, as HR1 refers to it, and foster youth that are aging out up to 24. They all lost their exemptions, so they are now included in that pool. Again, increasing that pool of folks that have to do work reporting. But in Kentucky, we had 117 counties that were waived. They did not have to do that work reporting. And that's because in the Farm Bill, you had two ways that a region could be waived. One was they had greater than 10% employment for a period of time. And the other one was that you could demonstrate that statistically there were not enough jobs in a region, not enough jobs to serve all the folks that needed a job. And so in Kentucky, we were able to demonstrate that 117 counties did not meet that criteria and got a waiver. HR1 removes that option and leaves only the 10%. Right now in Kentucky, we don't have any that classify. Now we're trying to get some data together and we're working on a few counties, but it won't be 117. We did receive a letter from USDA that said that our waiver that was supposed to expire November 30 was expiring October 30, and that we had to immediately go in and mark those counties as no longer waived. So we had shut down, and we had that waiver expiring November 1. And we were putting in all into place all these things, the 18 to 54 going up to 64, the dependent change, all of those things were hitting November 1. And the reason is that USDA was enforcing the hold harmless clause. The hold harmless says that you have 120 days to implement all these changes from the date of passage. That was July 4. So states had to do this by November 1. So we had a mad scramble to get all that done while under the shutdown. This created a lot of issues for folks because what was happening in states was people were not getting their SNAP benefit, but they said, well, do I have to report for work? And USDA said, well, yeah, you have to. Fortunately, we did get a memo from USDA, and they said that we could uh, waive off those folks that would have received a bad month in November. So, so just the other night, we ran a data fix on our software. We removed that bad month, so the November month will not count against folks for their work reporting, and that's good. But we are going through the process of, and we've been working on training our staff. We've updated our systems. We've implemented everything in HR1 that needed to be done by November 1. And now what we really got to do is with your all's help, get the word out to folks that they've got to do this. Reaching some of those communities is challenging, and they're not used to having to report their work for SNAP. So that's the challenge ahead of us right now, is making sure that folks know about these changes and what they need to do in the new reporting requirements. So that's kind of it in a nutshell, I think, Dustin. Did you have a specific question or?
No, one thing I wanted to highlight is there were certain exemptions for folks like veterans and former foster care youth and homeless. And I've heard you mention before there's a pretty significant number of folks who are receiving SNAP benefits who are homeless who may not have that exemption anymore. Is that right?
That's correct. Yes. Our data indicates that somewhere around maybe 7 to 8,000 folks.
Yeah. So that's a group in particular that I think folks on this call can help get the word out to, that they're going to need to either start reporting some type of community engagement hours that qualify under SNAP rules, or they need to find some type of exemption around a documented disability in order to maintain their SNAP benefits, which is obviously extremely critical for that population.
Right. And of course, I just want to remind everybody, HR1 did not change the work requirements, the hours. Folks can still volunteer, they can still do unpaid work, they can still do SNAP employment and training and all those other things. So fortunately, HR1 did not affect those things. So people do have those options, and that's one thing we want to try to do is educate folks. Just because you don't have employment, you could be volunteering or doing something else to meet those requirements.
Great. Well, let's shift quickly to Medicaid. We're running a little behind. I want to try and catch us up. Veronica, I know there's a whole lot of changes coming to Medicaid that you all are preparing for, and others that are maybe further out on the horizon that you're aware of, but aren't the most pressing. Can you walk us through some of those?
Absolutely. Thank you, Dustin. And I'm one of those in DC, attending the National Association of Medicaid Directors conference, and Commissioner Lee is in meetings as we speak. And we do hope, just want to kind of let everyone know that CMS, the Centers for Medicare and Medicaid Services, will be represented here. They are attending. So we were glad that the federal shutdown ended and allowed their attendance. We hope to have some additional conversations or hear from them as we meet this week on trying to help fill in some of the details of HR1 implementation. The particular ones I think we're most interested are those that take effect next year. That includes October 1, a change in the definition of an immigrant who qualifies for Medicaid, as well as on December 31st, and that takes place October 1. And then December 31st next year, the two kind of big ones, I think, for most folks, which are the work or community engagement requirement and the 6-month redeterminations go into effect. And then January 1, 2027 is also pretty critical because that also impacts how far retro back we can do someone's enrollment, limiting it to 1 month for expansion and up to 2 months for other individuals. So really what we're most interested in is trying to get those details from CMS about what are states' discretion and flexibilities, in particular around attestations, the identification of who might have an illness or disability beyond, a Social Security disability that will allow us to exempt folks from community or work requirements. I think that's our primary focus right now. CMS is required to issue a rule by July 1 next year or June 1 next year, which is a little too late for us. And so we really need to know now in order to start working on our system changes, working with folks to make sure they understand what the requirements are going to be for them. We're going to have to give notice to impacted individuals. And this is the expansion population, age 19 to 64. So this isn't everybody, but it's folks that need this coverage and need to be eligible for it and to continue to have the coverage that we've been able to afford them through our expansion. So we're just trying to fill in the details. I was here last week meeting with various vendors who are offering solutions for the community engagement requirement, trying really focused on how do we make that easier on the individual having to report or to navigate those requirements. So we are looking for solutions that will help them understand what action they may need to take. So that is a really very short explanation of what we're looking at right now, but happy to answer any questions.
Yeah, and then of course, further out, we have to start changing the way we do provider taxes and state-directed payments. But as far as what we're preparing for, this is the horizon.
That's right.
Great. David, I think you're on with us as well. I know you're about to talk a lot about what's going on with this current open enrollment, but can you share a little bit about what HR1 changes in terms of how we use the marketplace?
Yeah, gladly. I've dumped into the chat too 4 pages of timelines. For each program, there's Medicaid, there's Marketplace, and there's SNAP. Kind of very high level of what's there. We use that as a desk reference, so you all can do. On the Marketplace side, this year the changes were very few coming from HR1 as far as impact goes. Many of them were ones that only applied to the FFM or things that we could opt out of as a state-based marketplace. One of the reasons that we like being a state-based marketplace. We did lose the ability to enroll people by special enrollment if they fall below 150 FPL, federal poverty level. That was really helpful for people who were in the transition and then almost quite to Medicaid, but not quite there. So that was probably the biggest loss from HR1 directly for what we're doing now, because at least a lot of it doesn't apply. Coming up on the horizon, biggest change for Medicaid, Medicaid is all, rolling, but we always think in terms of plan year. So for next year's open enrollment is going to be shorter. It's going to end on December 31st by federal law. We will not have the state flexibility to extend it. And the coverage for lawfully present persons will be identical to that in SNAP now and what Medicaid is going to be. That's actually a huge shift because right now, all you have to do is be lawfully present. You can be a student. I've never seen it in real life. You could be theoretically be a tourist as long as you can prove you're going to be here the entire length of your enrollment. But now it will be the very narrow group. So whole swaths of people will no longer be eligible for any kind of health coverage. which is it's terrifying, to be honest. Then the next year is when the big one comes, and that is where theoretically we don't know how we're going to do it, but the requirement will be that we need to verify basically their entire application, their family size, whatever that means, because it's tax filing status, remember, their residency, their income, before they're allowed to enroll for plan year 2028. So we don't even know in theory what that looks like. But that's of the most concern going forward. It was a perfect storm. So the worst, I think this is supposed to be my next part, but I'll kind of segue in, is that what was not in the big bill.
Right.
And that was the enhanced tax credits. And that's the biggest hurdle that we are overcoming now. And being honest, that will be the biggest hurdle in the future, because as the healthy people withdraw from coverage, the risk pool goes up. And you think the premium raise was bad this year, it's going to be exponentially worse in 27, 28.
And there was also a change to the way $0 premiums work from HR1. Is that right?
Not for us.
Oh, good. Excellent. All right.
State-based marketplace.
Yeah,
Yep.
that's the best.
Yeah, on the that was a little unprofessional, sorry. But no, it's exciting. Like, yeah, on FFM right now, the healthcare.gov, if you have a $0 premium, you actually have to pay a $5, whatever they're calling it, to activate your plan, and then that somehow gets credited. Right, confusion, right? Not here.
Excellent. Great. Well, with that, I'm going to hand it over to Priscilla to keep us going around open enrollment.
Yes. Well, David, you already subtly transitioned there.
You like that?
I love that. So for folks who may not know, open enrollment started November 1st, so just about a little over 2 weeks ago. There are lots of changes that are happening. And so turning it back over to David, can you give us a little bit of a snapshot? How has open enrollment started off? How have things gone so far in the first couple of weeks?
And just so we are on the same page, there is absolutely nothing that has changed. We need to get that message out. Sure, the premiums, what I talked about with the enhanced tax credits, but everything else about the mechanics, we are open for business. We have been open for business, and it's the same process. The $5 fee thing doesn't apply. People can enroll like they have before. So that's what we're hoping to push out. So how is it going, Priscilla? Well, we're at about I'm sure we busted through 79,000 enrollments this morning, which is okay. It means that we're slightly below where we were last year at this time. But remember, we had a 30% increase in enrollments last year. So we're missing a bunch of people. It's hard to really tell. We're not doing this year versus last year comparison, because everything is skewed, if you will, by the exit of CareSource. They were our third largest insurer, and they left Kentucky altogether. So that means we have 15,000 people who were not automatically enrolled that would have been. So it's hard to understand how many of them are going to come back, and even what their premiums are going to look like. So that remains a challenge. But about 79,000 or so enrolled for 2026 already. We'll take that. That still is better than where we were when we came back from healthcare.gov. We're going to try to make sure we get as many people enrolled as possible. We've had over 2,000 new enrollees. We've had, since November 1, we've had 2,000 people come and sign up for health insurance. That's a shocking number. I was very surprised in a good way. Unfortunately, we have had over 2,700 people cancel their coverage for 2026 because they can't afford it. So those numbers are only going to probably get worse as we go, or we just simply won't hear from some of the people who were not passively enrolled. But that remains of concern. When persons try to disenroll themselves at the contact center, they're read a script warning them of what the repercussions may be. We're not the cable company. We're not trying to do a hard sale, but just what that is. Unfortunately, I'm not going to let this go by without an ask. Our airways are being inundated with plans that are not ACA compliant. Those do serve some kind of purpose, right? Short term or underwritten plans. But if persons sign up for something and then come to my staff, my team in May and say, it's not going to cover my surgery, can I sign up? The answer is always no. That is never a reason. So anyone who has ears to hear, please get the word out to be these. Some of them are good, but there are bad actors that are circling, and it's extremely fertile territory. We have had people who are downshifting. They're going from gold and silver into bronze, as expected. That can be kind of bad news because people are paying more for less coverage. So we worked really hard the last 2 years in particular to reverse that the other way. So, but at least they're staying covered. And we are trying to promote as kind of a last, it serves a purpose of the use of an HSA. The news blast there is all of the bronze, expanded bronze and catastrophic plans on the exchange are compatible with an HSA, regardless of the math. Ordinarily, they can't go over a certain deductible amount. They have to be, there's all this stuff that makes it HSA compliant. Now it's really easy. You buy that plan from us, it is HSA compliant. So we have seen people on the more affluent side, or small business people and whatnot, who are using that. And we have seen people who are kind of in the middle, where because a contribution to an HSA, unlike contribution to an FSA, that actually lowers your MAGI income. So it's one of those deductions like student interest and stuff that persons can take. So people with children can make the family decisions of how it best works for how MAGI is determined. And I did that all in one breath, Priscilla. Did I miss anything?
No, I'm always impressed by that. I have a couple of follow-up questions really quick. One thing that we are sort of hearing and seeing on social media from folks is there's a lot of confusion about what HSAs actually are. And some people think that HSAs are an alternative to like a health insurance plan. I'm pretty sure KHB has put together an explainer about HSAs. Is that something that you can do just like a quick
Yes, so an HSA is a health savings account that you take money from either your employer or your employment. You don't have to be employed through someone who sponsors this, like some plans. And then you set it up, think like an IRA, if you will, for health issues. Then you can use, and that's pre-tax. That's the first part of it. That's pre-tax. Then you can use that bank that you're saving up to pay for a whole plethora of medical expenses, basically everything but a premium. You can use it at the doctor, you can use it at the drugstore, you can use it at Kroger, as long as you're buying medical, keep your receipts. But when you're using it, there still is no tax. And if you dump enough money into this thing over the year or more, because it just rolls over year after year, that can gain interest if you invest it in mutual funds or something like an IRA. And that income is also not taxed. So the good news is it's the single most efficient tax leverage vehicle in the tax code. The bad news is you have to have an economy to be able to use it. We do have an explainer that also is a direct link to each of our issuers who are offering bronze plans. They actually have a how to set up an HSA. You can actually go through them actually if it's a little bit too confusing. And I see something attached. We really want to know how premiums have changed. All right, there's two magic numbers. Magic number one is about 26% average, or up to 40%. That's how much the premiums themselves have been raised by the insurers. So if you were buying a full price plan in WellCare, you could expect to see it's 40% more or change next year versus this year. That's not really the big news though, because the big news is with the enhanced tax credits not being extended. That was before COVID, they were calculated in one standard. Then during COVID, way back when, they changed the math. And working in the background, it's utterly fascinating, but I won't bore you with it of how we get there. It made it more generous for everyone. It also made it for people over the 400% FPL threshold, they could qualify as well. They changed it back. That's what is sunsetting. So people can still get tax credits, but they're less. So premiums are going up and tax credits are going down. That's the perfect storm. The majority, 58% or so, are seeing an increase of $100 or more per month. 10,000 Kentuckians are seeing an increase of $500 or more per month, and some are seeing increases of over $1,000 per month, which of course that means they're uninsured. So
Right.
I hope that answered it too. What's next?
That's super helpful. Backing up a little bit, can you tell us how many lawfully present residents will no longer be eligible for premium tax credits come January 1?
1,372.
All right, that's super
That
helpful.
we know about.
Okay, that's a really helpful number. So it's still a chunk of people.
Yeah, it's small compared to how many are on Medicaid, but it's still a group of folks, and they can still buy a qualified health plan, but for 2026, they're not eligible for tax credits.
Right.
If you want to get the word out there, it's if they are estimating their income to be less than 100%.
Wait, sorry. If they're estimating their income
if they're estimating that their income for 2026 will be below 100% FPL,
then they will not be eligible for premium tax credits.
Which is not necessarily what their income is now.
Right. Okay. And then if their income is going to be over 100% of the federal poverty
they're fine.
line?
Yeah, between 100 and 400, like the original pre-ARPA rules.
Perfect. And so for folks who would not be eligible for premium tax credits, they are still eligible to buy a full price plan. That's just not going to be a realistic option for most people.
Depending on the age.
Yeah.
Yeah. Because since insurance companies can no longer charge for pre-existing conditions, gender, all that ugly stuff, the big driving factor in premiums is age. The young invincibles can probably get a catastrophic plan for couple $100, and it's $1,800 and plus for that same plan for a 60-year-old.
Right, that's a huge gap in premiums. I mean,
5 times.
That's wild. And thank you for dropping the HSA fact sheet in the chat. That's also very helpful, folks. Please feel free to share that around. Again, we are hearing that from people on the ground, just like that confusion about what an HSA is, that you do have to be enrolled in a plan to enroll in an HSA plan. It's not an alternative. Some of the alternatives are some of the things that we don't want to talk about, but like short-term limited duration plans. There are the healthcare sharing ministries, things like that. Those are true alternatives, and HSA is not an alternative.
Yeah, because HSA, you have to be enrolled in a compliant plan.
Yeah. I think that's part of the messaging that we also want to make sure that we're getting out there, that just understanding that difference, because people don't know and they think, okay, well, I can skip buying health insurance and just get an HSA, and that is not how that works.
And someone dropped into the chat about they clicked on a non-compliant plan on Facebook or whatever it was. Yeah, it's unrelenting. I did this as a test myself, and I got 100 phone calls in less than 12 hours of people trying to sell me junk. So that's what we're up against. We're doing the best that we can market and all of this stuff. We are state government, right? We can only do so much, but that is what we're up against. So I dumped in on how to find an insurance agent. New for this year, our insurance agents, when they sign on to register with us, not only do they have to be licensed by the state, appointed by a health insurer, etc., they have to agree that they will not sell a non-compliant plan without documenting that they have explained to the consumer what they are buying. So that means if someone is a bad actor, one of our insurance agents, we've never had a complaint that we had to take action against, but if they do and sell them a junk plan, then when they get sick, they get to sue that insurance agent on their omissions and insurance themselves. So we added that as a little clause and explained it to them because we absolutely want people doing the right thing.
Yeah, that's really helpful to know. That is a great guardrail. I did not know that before this, so thank you for sharing that. So for folks, and I just have like one more question, then we can turn it over.
Yeah, I get 2 minutes, and then we'll still be on schedule.
For folks who do, I know you said this earlier, and KBH, we've put together a great junk plan explainer just to explain what that looks like, what those plans, what to be aware of, how they can be predatory. For folks who say accidentally get enrolled in a junk plan, or they're working with a bad actor agent who says that they're enrolling them in a compliant plan, but then maybe turns out that they don't. I know that doesn't quite happen as much here in Kentucky as it does in other states, but if that were to happen, what's the best course of action for folks?
It depends. If we have someone come back to us late January, early February, line up and says, I was working with this KY Next thing and I got this, I don't know. We do have a special enrollment reason called unaware. And it sounds murky. It gets even weirder. There's no federal guidelines of what that means at all. They were just unaware that they should have enrolled. We can have a little bit of grace within that first couple of weeks, maybe a month, if someone really is confused by somebody. Now, if someone voluntarily disenrolls themselves from a qualified health plan and signs up for something that's $35 a month and then comes to us in March or April or May, there is absolutely nothing we can do.
Okay.
So that's the gravity of it. And these ads that I signed up for, I got like a burner phone to see what would happen. Oh my, were don't pay $700 for your premium for you and your wife. Sign up here for $49. So it was smart enough to know what my premium would have been if it had been 2 51-year-olds.
Yeah, that's interesting.
So terrifying. So anyone that can do anything, I know DOI is coming up kind of with an explainer. We're going to be pushing that as well. Anything that you can get out there is to get people in the right plans. Yes, we're open. I can't tell you to go call your congressman, but December 15th, do whatever you need to do on December 15th for the enhanced tax credits. Because that's our Alamo. That's our last chance.
Yeah.
And then get the word out that to sign up for something that's going to work.
And if something does happen in Congress, KHBE is prepared to act, can still act, is prepared to switch things up if they need to.
We have a change request that's ready. We haven't submitted. We can't spend money based on rumor, and we have a contingency plan with basically remarketing the open enrollment again. We probably will not just extend open enrollment carte blanche for all kinds of reasons. But last year during the flood, during the tornado, we had a special enrollment reason where you could just attest that you were affected by the tornado, whatever. We'll do something similar where people can attest that I was affected by the federal changes and I need to enroll to extend the time for people to either enroll or change their plan so they get in the best plan possible. So we have a contingency plan ready. But it really kind of is the last chance.
All right. Well, I will say it because David can't. Call your legislators if you're seeing that high premium, if you're, hearing family, friends, community members with a high premium, sticker shock, call your legislators, let them know how important it is to act and to give us some relief for the plan year 2026. And
it is far more effective when a constituent calls. When an advocate calls, they listen. When I call, I don't call. They listen. But if someone who actually has this bill and they are going to die because they have life-sustaining drugs that they cannot afford, then no matter how jaded, they listen. All
right. Well, on that
Thank you, Priscilla.
Thanks, David. I appreciate you being here and sharing that. And if folks need any help, make sure to reach out to a connector or an agent. And so with that, I will turn it over to Dr. Schuster.
Thank you very much. I'm Sheila Schuster, Executive Director of the Advocacy Action Network. And the waivers feel like they're in the weeds, but these are really exciting opportunities to offer special services for people that are eligible for Medicaid, but need some additional services. So the first one that we're going to look at is the reentry waiver. And if you'll go to that slide, I think it's just a lead-in slide, Alex. Yeah. And we're going to call on Dr. Leslie Hoffman to tell us about that.
Good afternoon, Thrive community. I'm so happy to be on with you today and to give you some updates. So our reentry program is going well. If you've not been on or listened to us before, it has been approved. We are in kind of the preparing, readiness, and implementation phases. So let's just go over a little bit of history here with you. Who's eligible? And that's all adults and youth who would be eligible for Medicaid if they weren't in incarceration or confinement. What settings are we talking about? And that would be the Department of Corrections, DOC, state prisons, the Department of Juvenile Justice, DJJ, and also our youth development centers, which we call our YDCs. What services are we looking at in this 1115, which is a flexibility for our state? Case management 60 days prior to release with a 12-month post-release follow-up by the MCO of their choice. Medication-assisted treatment, which we call MAT, and counseling for individuals diagnosed with substance use disorder, SUD. We are looking at that for 60 days prior to release as well. Also, a 30-day supply of clinically required prescription medication, and if applicable, any durable medical equipment that that individual might need immediately upon release. That does cover, of course, medical as well, physical as well as behavioral health medications. It's anything that that member needs as far as that 30-day supply goes. Let's talk a little bit about our program updates. The program design for the delivery of pre-release services is already ongoing, including work group discussions with DOC and DJJ and our Department for Community-Based Services. This has been a multi department in the cabinet as well as outside of our cabinet, and also with our MCO partners. You've heard me speak before. This has been one of the most complex programs that we've ever worked with, but Team Kentucky can definitely do it. The project team is actively working to ensure system alignment across all platforms, with system testing occurring through 2025 and maybe just a few weeks within early January. DMS will continue to collaborate with our justice partners regarding credentialing processes and our managed care organizations. Provider training and readiness will continue through 2025 and go into early 2026.
Next slide, please.
Next, yeah, thank you. For our Consolidated Appropriations Act, CAA, that is, we're required to comply with Section 5121. And there are other sections that we're taking a look at for pre-release. Youth who are Medicaid eligible and incarcerated and found to be Medicaid eligible during placement. And this also includes under age 21 or former foster care, which is age 18 to 26. Our settings at this time will be the Department of Corrections, state prisons, and our youth development centers through our Department of Juvenile Justice. What services are we looking at? It's very, very similar to what we're looking at for the adults. Screening and diagnostic services, including medical, dental, vision, and behavioral health screenings or diagnostic services, 30 days prior to release. So this one's a 30-day prior to release, and the adults is a 60-day prior to release. Targeted case management, 30 days prior to release, and for at least 30 days after release. So on the adults, we have a flexibility to follow them with the MCO of their choice for up to 12 months. Program updates. The state plan amendment has been approved for the CAA targeted case management and for the screening and diagnostic services. I was told that we were the first in the nation that had their state plan amendment approved, so that we were the first. That was really good. The alternative benefit plan, ABP or a SPA, I think that is currently in process as of last week. That was the last information that I had seen with Commissioner Lee. The CAA grant has been awarded, and I left this on here. I could have taken it off, but I wanted to tell you something that we're working through. The CAA grant was awarded, I think, back in February. We were supposed to have a kickoff in August. They moved us from cohort 1 to cohort 2. We still expect it to kick off in August. And as of right now, today, even though we've been approved, they've not released the funds. We don't owe them anything. We are just waiting for them to release the funds. They've assured us that we're going to get the funds. The funds for the CAA grant were actually for our sister agencies to assist our DOC and DJJ partners in compliance and setting up part of their infrastructures. So I'm very hopeful. Just as of this morning, I was still hearing that those funds should be on the way. Can't promise anything, but that's where we are. Sorry, Dr. Schuster.
And are we looking at the reentry actually starting in April of 2026?
That is still our date right now. As you can imagine, we've got a lot of things to work through. The system changes are the most complex, and working with two cabinets, right? We're working with two cabinets. One of the things that we have had to be very watchful of is DJJ is actually setting up their own new system in the midst of all this. So they're trying to work on their new system that mirrors the DOC system. So we're having to work in parallel with everything together. So it's not really caused us a lot of time delay, but it's just the complexities. I always say it's like an onion, and every time we meet, we peel back a layer, and there's something else
There's something else, yeah.
Something that we haven't thought about. Yeah, sorry.
Yeah, thank you, Leslie. In the interest of time, let me go on to the child waiver,
Yes.
or have you go on to the Community Health for Improved Lives and Development child waiver. Thank you.
And I'll go over this. If you all have listened to us speak about the child waiver, what is the child's waiver? And I think you're probably familiar with this. The child's waiver is a new Kentucky Medicaid program designed to help those children that are the hardest of the hardest, the most severe with behavioral health and developmental challenges. We're serving the children and youth with most complex needs. The waiver includes things like clinical therapeutic services designed to foster a step-down approach, coming from the highest level of care to help them return to the community. So what we're trying to do is keep that child in the community, and hopefully that we can intervene at an earlier stage and help with their intensive behavioral health and residential support needs.
Yeah.
Who does this child waiver help? Under age 21 with behavioral health or developmental needs. This is a child that is in need of care like they would be receiving in an inpatient care or an intermediate care facility for individuals with intellectual disabilities, developmental disabilities, and that's what we call an ICF-IID, and or a hospital. And remember that they have to be safely supported in the home or in the community. This is an HCB waiver, so they have to be effectively providing the services in the community. Next slide. This enrollment is targeted to those who have exhausted supports and services and enabling them to remain in the community. They are at maybe high risk of being unhoused, have a history of at least 2 different foster care placements, have at least 5 contacts with law enforcement, is discharging from an institution in the next 45 calendar days. Dr. Schuster, I've been asked several times if we're giving first priority to DCBS individuals, and that's not. It's whoever applies and who meets the criteria. So it may likely be DCBS children, but everybody has the ability.
That's not a set priority.
That's correct.
These enrollment.
That's correct.
Okay, and then the last slide.
So this is all good news. DMS received CMS approval for the child waiver on November the 6th. We're very happy about this. Our long-term services and supports division within Medicaid has been spot on. I'm so proud of them. This is led by Carmen Hancock, and April Lowry has also been working on this. We've had significant provider outreach, enrollment, and training is all on its way. Last time I looked, we had over 204 providers that had reached out wanting to provide services. We've had provider information sessions at 1 p.m. Sorry, we've got some more coming up. 1 p.m. on November the 18th and 10 a.m. on November the 21st. So those links do work. And in-person provider orientation will be held in Frankfurt on December the 16th, and more to come. I believe it's going to be at the Transportation department, but I'll get more information on that. I think they're securing the room now. If you have any questions, you can reach out to us. You can reach out to me. We're so very pleased that we're so close. We do have a January hopeful date still and still planned.
Okay.
So if you have any
January,
questions, just reach out.
January of 2026.
That's correct.
Wow. Okay. Thank you. Thank you
Yes,
so
ma'am.
much, Leslie. Appreciate that. And that's a quick turnaround on that child waiver. It feels like we've been waiting for reentry for about 5 years. I know you have been. So thank you very much for that. I want to shift now to the 1915I RISE initiative and ask Tanya Dickinson, please, to update us on that.
Hello, everybody, and good afternoon. I apologize up front for my voice. It'll crack a little bit, but I'm not as bad as, don't feel as bad as I sound. I'm with the Department for Behavioral Health, Developmental, and Intellectual Disabilities, helping with the implementation of the 1915I RISE initiative. And I'm sure that most of you are aware of what that is, but I'll give you just a quick overview for those who might be new. Next slide, please. Thank you. 1915I RISE stands for Recovery, Independence, Support, and Engagement in the Community. It is a new Medicaid benefit under Kentucky's 1915I state plan. We received the final approval for that very end of March, 1st of April, and have been working on implementation since that time. It's a program that is designed for Medicaid eligible adults who are 18 and over with a serious mental illness, with or without a co-occurring substance use disorder. We've had, the program offers 10 essential home and community-based support services, helping individuals become successful in the community after they've either been through a psychiatric placement or perhaps in jail, or perhaps are currently living in the community but need additional services. And those 10 range from assistive technology, case management, housing and tenancy supports, and in-home independent living supports, medication management, planned respite care for their caregivers, supervised residential care, supported education and employment, and non-medical transportation. Every individual accepted for services receives a case manager who then helps them negotiate obtaining those other services from certified providers. As an individual who is referred to the program for services, they will receive a pre-screening to make sure they're just have that basic eligibility, and then a more in-depth assessment. These are conflict-free. They're individuals who are employed by Department for Behavioral Health, Developmental, and Intellectual Disabilities. And then they're referred to a case manager who's also been, their provider agency has also been certified to provide those services. They work through those pretty now. We have been working on recruiting providers and are not quite, but almost ready to start accepting individuals referred to us for the services. Like I say, it's a Medicaid program. So an individual who is referred to this program will be there. If they're being served now by an MCO, they will convert to standard Medicaid, and that will be reimbursed. Those costs will be reimbursed out of Department for Medicaid Services directly. Individuals cannot receive both 1915C waiver and 1915I state plan at the same time. But for instance, somebody who's been on a waiting list for the 1915C could join the 1915I program. There are other programs currently offered in the community and Medicaid supported, such as assisted outpatient treatment, ACT, that they could also be receiving simultaneously. Slide, please. The service requirements for for providers who, to define what it is they must provide for each of those 10 services, are in the Kentucky administrative regulations. And I've put that along with our links for that, along with links to our website and our provider email, and the provider directory for when we have individual programs certified in the chat box. There's also the Medicaid fee schedule. And then kind of a quick that's sort of the broad overview of what the program offers. The quick overview of our current status is that we've got 5 certified providers so far. I'm expecting a couple more, hopefully by the end of the week, first of next. And we have a total of about 70 somewhere in the process, from having downloaded the application for certification or working their way through the review process. It's not I don't think it's a difficult application process, but it's a lot like applying for a federal grant. There are a whole lot of details that have to be completed and submitted and organized in a particular fashion to comply with the regulation and the state plan amendment. But we've been working with the providers directly to help them get through those, help some of them get through a little bit of anxiety about that. There's also some external agencies that are working particularly on the housing, the supervised residential benefit. Those providers are the ones who've really never been exposed to Medicaid before. And so Kentucky Housing and some of their support groups, they're working on providing a dedicated Medicaid academy, if you will, for those kinds of providers. We've also been working on some more creative solutions to work with individual providers to kind of get them speed up their certification, help them through that with some more individualized attention. And we also offer an office hours for providers from 3 to 4 every Monday to help them work through their individual questions that they might have, either prior to or after they've been certified, and those have been very successful. We've had lots of great questions that have helped us guide how we're serving the other providers. Like I mentioned, we are very close to beginning to accept participants for the program, but we're waiting for that sweet spot of having enough providers to provide the services across the state, so that we can give them the necessary choices that they'll want to be able to have. And I will wrap this up really quickly. I don't think there's anything else to add beyond that, other than we are really happy to be working with the Department for Medicaid Services on the implementation of this program, and always very happy to answer any questions that you may have. If you are aware of individuals who would like to be participants in the program, we're not yet accepting referrals, but there is no waiting list. But if they would like to send, they or someone that they are that represents them would like to send an email to the general inquiry email, 1959 RISE at KY.
Do that. Yeah.
We'll follow up with them as soon as we're ready to. And that's it.
All right. Thank you so much, Tanya. We have been waiting, and I'm so glad to hear that more providers have signed on. So that's really great news. I've heard great, very positive things about you all offering those office hours.
Excellent.
So just a reminder to everyone that there's upcoming events and announcements. I want to thank particularly our colleagues over at the Cabinet for Health and Family Services for sharing your expertise and information with us. And I'd like to thank everyone who joined us today. Please look for the follow-up email with the slides and your evaluation. And if you need a CE, you need to fill out that evaluation. But we would really love for everybody to fill out the evaluation. We're very pleased to be in partnership with CHFS to be doing this program, and we look forward to seeing you all in 2026. So I will wish you all a happy Thanksgiving, since we're giving thanks to people And, I think the great thing is the amount of cooperation, collaboration, and partnership that we have on behalf of all the people of Kentucky. So thank you very much. Wishing you not much rain the rest of the day and maybe sunshine tomorrow. And happy Thanksgiving to you. Bye-bye.
Bye. Happy Thanksgiving, everyone.